Well, hello everybody. For those of you who don't know me, I'm Patrick Kenney. I'm a second-year fellow here at USF Department of Infectious Diseases, and tonight we're going to talk about Legionella. And just to go over some of the objectives, we talk a little bit about the history of the infection. It's the microbiology, pathogenesis, a little bit of epidemiology, environmental ecology and transmission, the clinical manifestations, diagnosis, treatment, prognosis, and prevention. So, to talk a little about history, in 1976, I believe it was the 58th American Legion Convention in Philadelphia. Many of us have heard this story, but it happened at the Bellevue Stratford Hotel. There were about 4,000 attendants of this convention of the American Legion. 600 of these attendants were staying at the hotel, and people started exhibiting symptoms on day 2 of the conference, and for several days afterwards, more and more people became ill. 220 people became sick, 34 passed away, and they were able to isolate the organism, but it hadn't been named yet. And in the following January, the organism was identified and named Legionella after the conference. And then this organism was then retrospectively linked to an outbreak in Michigan in 1968, after about 100 people became infected with an acute illness that was febrile with myalgias and headache, and they isolated the organism and found that this was also Legionella. However, this disease was self-limited, whereas the other disease in Philadelphia was more pneumonic in nature. So this is just some of the news clippings from the time, mystery killer fever. And this is just a shot of the hotel where this outbreak occurred. So a little bit about Legionellosis, because that encompasses 2 specific disease entities known Legionnaire's disease, which was named after the 1976 outbreak, which is the more common syndrome of the 2 of pneumonia after inhalation of Legionella species, namely Legionella pneumophila. Pontiac fever is again named after that health department in Pontiac, Michigan, where this outbreak occurred. And this is more of an acute febrile illness that's self-limited, and it's linked to inhalation of Legionella species. A little bit about its morphology. It's an aerobic gram-negative rod. It does not grow on routine bacteriologic media. The media which it does grow is the buffered charcoal yeast extract, and it usually takes a little bit of time to grow. It takes about 3 to 5 days post-incubation to grow. So how does it cause disease? Well, after the organism is aspirated, the organism attaches to the respiratory epithelial cells and the alveolar macrophages via its flagellae and pili. The organism is then phagocytosed through a process mediated by monocyte complement receptors and other complement pathways, and the major outer membrane protein of the macrophage infectivity potentiator protein, that's a lot of words, MIP for short, is on the surface of the Legionella organism. But Legionella is smart. It evades the intracellular destruction by inhibiting phagosome and lysosome fusion, and the genes that are responsible for this have been identified as DOT, defective organelle trafficking, and ICM, intracellular multiplication genes. And they've discovered that organisms that are deficient in these genes are non-virulent. And then ultimately they are killed once they are phagocytosed. So once that evasion has happened, Legionella then forms pores in the lipid membranes and a number of cell types, which allows small molecular weight substances to enter, which prevents acidification of the phagosome, which precedes phagosome lysosome fusion. And there are also several virulence factors that aid in its multiplication intracellularly, apart from these DOT/ICM genes. There is inherent beta-lactamase production. There is an exotoxin that is produced, and those are named there. They also produce a weak lipopolysaccharide endotoxin, and the carbohydrate lipopolysaccharide can activate the complement pathway. The flagellae also are pathogenic as well, and they can be recognized by monoclonal antibody 2. And this is just a nice, colorful picture of the infection cycle. You can see the organism being phagocytosed into the macrophage, and with the help of these genes and its virulence factors, it is allowed to multiply inside the cell and be exocytosed to infect other cells. And then how do we handle the infection? Well, it's usually done by cell-mediated immunity, as with other intracellular organisms. And there is some humoral response to the infection. However, the antibodies really don't really promote any complement-mediated killing, nor do they inhibit the intracellular proliferation of Legionella. The cell-mediated immunity is suppressed by glucocorticoids, as well as some of the other immunosuppressive agents and anti-rejection medications we use in our transplant patients. And this predisposes the host to Legionellosis. Also, patients with hairy cell leukemia are also increased risk because they have monocyte deficiency and dysfunction. A little bit about the epidemiology. Legionnaires' disease accounts for about 2 to 9% of community-acquired pneumonia infections. However, this number has increased over the past 10 years due to more accurate testing and more aware and more astute physicians. The total number of cases in the USA has tripled from 2000 to 2009, again to better testing, and there has been literature to suggest that warmer temperatures and higher amounts of rainfall have led to an increased incidence of Legionnaire's disease. In the hospital, it really depends on the presence of the organism in the water supply. In some areas, Legionella can colonize 12 to 70% of the hot water distribution systems of hospitals. And again, the better testing, more cases of Legionella infection in the hospital setting have been detected, though it is still not a major cause of hospital-acquired pneumonia. In long-term care facilities, there have been outbreaks of not so much of Legionella pneumophila, but Legionella St. Helensii, and those were reported in Canada with about 29 cases within a 2-month period. Again, this was linked to a colonized cooling tower. The risk factors for these patients included a predisposition to aspiration, whether they had a neurologic deficit that gave them that predisposed them to aspiration, or they aspirated pureed foods that were prepared with colonized water. Travel-related instances and epidemiology, the European Working Group for Legionella infections and the CDC have identified several cases of travel-associated Legionnaire's disease. The most common cases were associated with contaminated water and cooling tanks in hotels, and the infections have also been linked to cruise ships. In patient homes, there have been some surveys and some case reports, as well as some prospective studies of community-acquired Legionnaire's disease from the drinking water found in people's homes. Nevertheless, the risk of disease in an individual residing in a home colonized with Legionella appears to be quite low, less than 5%. Some of the risk factors that predispose the host to the infection is cigarette smoking and chronic lung disease. This is all throughout the literature that I've read. These are the patients with the most common common risk factors. Transplant patients also carry a very high risk for Legionella infection. Heart transplants especially during episodes of allograft rejection. Nearly half of the cases were due to water contamination and were hospital acquired. Glucocorticoid administration, as well as some of the other agents and illnesses resulting in immunosuppression, were also the high independent risk factors. But interestingly enough, patients with HIV, acute leukemia, and neutropenia, acute leukemia, and HIV did not have an unusually high incidence of Legionnaires' disease, with hairy cell leukemia, as I stated before, being the exception. Patients receiving TNF-alpha inhibitors for autoimmune diseases are at an increased risk for Legionella disease, and some have developed severe and fatal cases of pneumonia. And then, children with innate immunosuppressive diseases or on immunosuppressive agents are also at risk. Where does this organism live? It tends to live in aquatic environments, including lakes and streams. However, the man-made reservoirs, such as cooling towers and water distribution systems, tend to have a higher bacterial load, given the higher water temperatures, the stagnation of these bodies of water, as well as the scale and sediment that's present. Also, the presence of other microorganisms tend to facilitate its growth, such as algae, amoeba, protozoa, as well as other bacteria that are present in the water supply. How is it transmitted? Most commonly is inhalation of aerosol. The most uncommon is inhalation of aerosols. However, there can be inhalation ingestion of potting soil, but mostly in, I've seen that it was documented in pediatric cases, aspiration of contaminated water. This is in the hospital. This is possible with flushing of NG tubes. There's also been pediatric cases where the children have aspirated colonized bath water, and then there's also direct inhalation into the lung during manipulation of the respiratory tract, like during a bronchoscopy, for example. Increased rainfall, and however, person-to-person transmission has never been reported, and that's important to know. How do these patients present? Usually the symptoms occur 2 to 14 days after exposure, and cough and fever being the most common. And then the other symptoms there. Important to know, diarrhea and neurologic changes are also important manifestations that you need to be aware of. And the rest of it. Many of them are very broad, but if you start seeing patients with these, please keep your mind open and look for Legionella. On physical exam, they may express rales with signs of consolidation, with egophony. Fever is almost always present. There is also a phenomenon with bradycardia relative to temperature elevation. That's commonly seen in the elderly patients with severe disease. And some miscellaneous findings, they're not specific. However, it has been reported with DIC, glomerulonephritis, rhabdomyolysis, rash, and neuropathies. And laboratory findings, you'll definitely be predisposed to a leukocytosis. Elevated transaminases and hyponatremia are very telltale signs that you may be dealing with Legionella. Hematuria, proteinuria, as well as elevated serum ferritin and elevated procalcitonin have also been documented. Chest X-ray, the fever may precede the infiltrate, but it's usually patchy unilobar infiltrates that usually progress to a consolidation. The infiltrates may be interstitial, and pleural effusions are very common with this disease. Some of the clinical clues that you may be dealing with Legionella: presence of GI symptoms, especially diarrhea; neurologic symptoms, especially confusion; fever greater than 39C, and then also your sputum gram stain shows lots of neutrophils, but no organisms are or if any, are isolated. Because if it's not, if your clinical laboratory is just doing standard media, Legionella, like we said earlier, will not grow. Hyponatremia, hepatic dysfunction with elevated transaminases, hematuria, and then a failure to respond to beta-lactam and aminoglycoside antibiotics. Their extrapulmonary disease does exist. It's usually from hematogenous dissemination. The most common site is the heart, with endocarditis, myocarditis, pericarditis as well, and it also affects prosthetic valves as well. Extracardiac would be in the skin, cellulitis, sinusitis, arthritis, abscesses have also been seen, but mostly in immunosuppressed patients. And there have been reports of surgical site wound infections in patients who have had their wounds irrigated with or rinsed with water that was colonized with Legionella. Diagnosis has, like we said, it has to be isolated on culture selective media. The buffered charcoal yeast extract agar is the gold standard, and it contains polymyxin, anisomycin, vancomycin, as well as several dyes, which allow the tech to differentiate between the various species. Legionella pneumophila dyes apple green on the media, and then there's the urine antigen testing, which is what we primarily use here, and that's an enzyme immunoassay. And since that's the one that's widely used, I'll talk a little bit more about it. And it is the testing modality that has been linked with increased reporting of the infection, both in the hospital and the community. But the test is only specific for Legionella pneumophila serogroup 1. And the advantages are it provides a diagnosis when a sputum sample may or may not be obtained. Patient may have may not be able to expectorate. There may be a neurologic deficit there, and it also provides a test result very quickly, within 1 to 2 hours, and the test is positive for several days, even during the administration of antibiotics. The disadvantage, though, it's only sensitive for the serotype 1. There are other methods, though not widely used. There is the direct fluorescent or DFA testing, which is highly specific but not sensitive, and it can be done if the direct culture of the specimen is overgrown by competing flora, but it's not widely used since we have the urine antigen testing. There is also serology, and as with a lot of the serologies we're finding now, it's really not clinically reliable, as many patients have a falsely elevated IgG or IgM titers because we can be exposed to Legionella, but it may or may not cause disease. And but if it is used, it's defined and it's considered positive. It's defined as a 4-fold rise in the antibody titer, and a repeat serology has to be done 8 to 12 weeks after the onset of infection. And the main modalities are the indirect fluorescent antibody assay as well as the ELISA. There is susceptibility testing done, but it's again not reliable. Conventional testing is we can't really use it to base our regimen, because in vitro testing hasn't really been standardized, and the buffered charcoal yeast agar binds antibiotics, so it falsely minimizes the effects of susceptibility testing. Conventional antibiotics that have excellent activity against Legionella in vitro have been shown to have little or no effect in patients with Legionnaire's disease, such as beta-lactams and aminoglycosides. So what antibiotic regimen should we select? We want to use a regimen that targets the organism intracellularly, and the antibiotics should be able to achieve a higher intracellular concentration than the MIC for it to be more efficacious. And those antibiotics are the macrolides, quinolones, tetracyclines, and rifampin. we tend to want to use the later generation macrolides, namely azithromycin, as well as the respiratory quinolones. They're more effective as monotherapy for Legionellosis than erythromycin for several reasons. They're more potent intracellularly. They have superior lung tissue penetration, and as well as alveolar macrophage and leukocyte penetration. And there are just improved pharmacokinetics with these medications, allow for once daily or twice daily dosing. And there's less GI toxicity as compared to erythromycin. And anyone who's taken erythromycin knows that it is hard on the stomach. And so for treatment guidelines for moderate to severe disease, again, we have our respiratory quinolones, levofloxacin and moxifloxacin, used for a 10-day period, as well as azithromycin. There is, as far as monotherapy versus combination therapy, rifampin can be added in patients with severe disease, even though benefit really hasn't been demonstrated, but it really hasn't been dismissed either. And if you have a patient who's not doing well, and rifampin can be used to improve morbidity, it is worth trying. As far as IV versus PO, medication should be initiated IV to remove the possibility of incomplete GI absorption. Like several of these patients have GI symptoms, so we want to make sure that we give them the effective treatment. And then after those symptoms have resolved and the patient's effervesced, we can then switch to an oral equivalent, and that to complete a 10-day course. Now, immunosuppressed patients, the guidelines recommend levofloxacin IV or PO for 21 days for patients with severe disease. For community-acquired pneumonia, azithromycin or respiratory quinolone for empiric therapy should be included. For nosocomial, again, levofloxacin is the empiric drug of choice. It covers many of the gram-negative bacilli that also may be causing the infection. In transplant patients, quinolones are the preferred regimen. Levofloxacin or Cipro. However, more studied centers are using levofloxacin because, unfortunately, the macrolides interact with cyclosporin and tacrolimus. Patients with extrapulmonary disease and endocarditis, there has been literature to use combination levofloxacin and azithromycin. There really aren't any guidelines for duration. However, in the American Heart Association, they did recommend that if the infected valve is resected, 3 months, and up to 6 months if the valve is not resected. In HIV patients, though Legionnaires' disease is uncommon in HIV patients, patients with HIV who do get Legionella, they tend to have a higher mortality and have a higher incidence of cavitary disease and extrapulmonary infections. So quinolones are preferred, as the macrolides may interfere with several of the antiretrovirals, but in this literature it talks about efavirenz and zinavirin, but many of the other antiretrovirals you can use some macrolides. For Pontiac fever, the antibiotics really aren't indicated. It's a self-limiting disease, and just supportive therapy can be antipyretics can be used. Prognosis: if it's treated early, patients tend to do very well, and in the United States, if the patient's immunocompetent, the mortality has gone down to less than 5%. But you shouldn't use the chest X-ray as a marker for clinical improvement because, as with many pneumonias, the chest X-ray may lag behind the patient's clinical picture. Now, the mortality does rise in those who therapy has been delayed, and those with pre-existing immunosuppressive diseases, as well as serious disease when they initially present. And then in vitro resistance to the quinolones and macrolides has not really been documented, even though in those with infection that has persisted on therapy. And so as far as prevention, goes, and as for many of us who will be on infection control committees, I thought this was important, that even though there is no isolation is necessary, as there is no known case of person-to-person transmission, the water in the hospital needs to be routinely tested. And even if Legionella has never been in the hospital, there just needs to be constant monitoring. And if there is Legionella found in the water, there are several steps that need to happen. You need to make sure that your clinical laboratory is able to test for Legionella, which many of the hospitals now do, with making sure they have the correct auger and making sure that they have the urine antigen testing available. And then also alert staff, physicians, to be more aware that this is a possibility that this infection could be showing in the hospital and the emergency room. And then patients who come in with come in the hospital who develop pneumonia to start empiric therapy for Legionella early rather than later. To disinfect the water supply, many hospitals and many cities use copper-silver ionization, and that's the current disinfection modality of choice. If in the case of emergency, you can superheat the water to over 70 degrees Celsius and then flush the distal outlets for 30 minutes. But that's only temporary. Chloride dioxide is promising, but the drawback lies in the amount of time it takes. It takes many hours to eradicate Legionella, and I mean it doesn't really help the patients. And then the modality of hyperchlorination of the water is now really obsolete, and it's expensive and very corrosive to the hospital plumbing. And there also is a concern health-wise for its association with spontaneous abortions and carcinogenicity of the chlorine byproducts. Does anyone have any questions regarding Legionella?
It was so good, I'm speechless.
Oh, well, thank you. Well, thank you very much. And these are my resources.